Welcome to the gastrointestinal system. For Block 1, the GI issues that we're going to focus on are going to revolve around the bowels, specifically diarrhea and constipation. Here are the objectives for our GI system. We're going to understand the basic anatomy and physiology, pathophysiology, signs and symptoms, risks, predispositions of the adult and elderly patients with bowel disorders. We're going to use the nursing process to care for adult and elderly patients with bowel disorders. We're going to incorporate knowledge of labs and medications consistent with the cause and/or treatment of adult and elderly patients with bowel disorders. And we're going to provide patient education to promote and maintain the health of the adult and elderly patient with bowel disorders. Before we can get into our bowel disorders, we need to briefly review the GI system's anatomy and physiology. The GI tract is what allows us to digest our food and get the nutrients from the food into our blood supply and our cells, so you may hear it referred to as the digestive system. Digestion starts with the mouth. We use our teeth and salivary amylase to break the food into smaller pieces that can be swallowed down the esophagus and into the stomach. The stomach secretes digestive acids like hydrochloric acid, pepsin, intrinsic factor, and churns the food to break it down into even smaller pieces so it can pass into the small intestines. The small intestine uses enzymes like amylase, lipase, trypsin, and bile that digest proteins and carbohydrates and absorbs the nutrients into the bloodstream by active transport and diffusion across the intestinal wall and into circulation. This is also where a small amount of water from the food gets absorbed, but the stool in the small intestine is still extremely liquidy and is not remotely solid yet. The liquid stool then moves to the large intestine, which is the primary organ of bowel elimination, and it's called the colon. The large intestine absorbs the rest of the water out of the food, and the food travels through the intestine. It will start as liquid in the ascending colon and get more and more solid as it travels across the transverse and descending colon, and it should be solid by the time it gets to the sigmoid colon. From the sigmoid colon, the stool will pass to the rectum and be expelled from the body through the anus. The large intestine is a very important organ when it comes to fluid balance in the body, as it will absorb as much water as it can to make sure the body is hydrated, and it will absorb less water if the body is already well hydrated. The large intestine also expels any undigested food, non-food solids, and any food waste products that haven't been used by the body or aren't needed. Now, there's a lot more to the GI tract than what I just said. The pancreas, liver, gallbladder all assist with making the digestive enzymes for the stomach and small intestines. We don't discuss any disorders with these organs in Block 1, but in later blocks you will, so you will need to refresh your GI knowledge again later. Peristalsis is the muscle movements of the intestines. It's the movement that makes your abdominal noises, your bowel sounds. If your stomach growls, that's peristalsis. Peristalsis is controlled by our nervous system, so some people with nervous system disorders or medications that can affect the nervous system can have peristalsis issues. Most people will have peristaltic contractions every 3 to 12 minutes, but we should always be hearing some sort of noise coming from the bowels. If we don't have any noises, there's an issue. The body typically will have a mass peristaltic sweep every 24 hours. That means they have a bowel movement, sometimes more depending on the patient. Some people have multiple bowel movements a day, and some people go once a week, and everybody has their own norm. And something most people don't know, 1/3 to half of your food will be excreted out of your body within 24 hours. We digest that quickly. Remember the first part of the nursing process, assessment. We can't determine if a patient is having issues with their GI tract if we don't do a thorough assessment. You've learned how to do an abdominal assessment, but to be able to really determine what issues the patient's having, we need to do a little bit more assessing. A good abdominal assessment is going to start with questions about their abdominal health. We need to ask about abdominal pain, any indigestion, which is called dyspepsia, any gas or flatulence, and bloating or feeling full, any nausea and vomiting or constipation. Do they have any changes to their bowel habits, or do they need to take medications that affects their bowels? We need to ask about fecal incontinence. Can they hold their stool, or does it come out involuntarily? We need to ask what their normal bowel movement habits are. How often do they go? What color and what consistency does it normally have? And does it have any odor? If they have abdominal pain, we need to ask more questions about what makes their pain better or worse. Where's the pain? Does the time of day affect where their pain is, or does it affect the change of their pain? Or is their pain just constant? We also need to ask them about their mouth. The mouth can have its own problems that can affect their bowels. Asking about pain locations for abdominal pain is really important because abdominal pain doesn't always reflect the exact location where the problem is. Abdominal pain has a lot of referred pain locations. Referred pain means the pain is occurring in a different location than that body part that's having the issue. The disorders we discuss in Block 1 don't typically have a lot of referred pain locations, but the higher level blocks GI disorders, they do. So look at the shoulder of this patient real fast. That's where a lot of people are going to have their liver pain, but the liver is nowhere near the shoulder. So referred pain is really important when it comes to the abdomen. As you've already learned, the sequence for abdominal assessment proceeds from inspection, auscultation, and percussion to palpation. You already know all of these and what you're looking for, so I'm not going to repeat them. During a head-to-toe assessment, we look at the 4 quadrants, but we can actually break the abdomen down into 9 regions. Using the 9 region names really helps to pinpoint where the patient is having pain because it's more specific. For example, if I call a provider and tell them that the patient is having epigastric pain, it helps them determine what problem could be because it's more specific than saying they're having upper abdominal pain. These regions are more commonly used in the higher block disorders, so you will be hearing about them again. Assessing someone's rectal area is very important for skin, so you're going to hear about this region again when we discuss skin and wounds later in the block. But when we assess the rectal area, we're looking for any skin breakdown, any lesions, any ulcers, fissures, inflammation, and external hemorrhoids. All of these could be caused by constipation or diarrhea, and they can all cause major skin and pain issues. The reason why we ask so many GI-related questions and assess the abdomen and rectal area is because there are so many things that affect bowel elimination. And in healthcare, we can affect so many of these at one time, and then we wonder why the patient's having bowel issues. The first thing we need to take into account is patient development. We don't discuss any children of any age in Block 1, but children have to learn how to voluntarily have bowel movements. Adolescents and adults have voluntary control over their bowels unless there's some medical conditions that's affecting this control. As we age, there are several age-related disorders that can take away this voluntary control, causing the older person to have incontinence, which is a loss of bowel control. Every person has their own daily bowel movement habits and patterns. If the person normally goes every day and now it's been 4 days, we may have a problem. If the patient only goes once a week and now they're going twice a day, that could be a problem. Food and fluid can affect our bowels. Some foods are constipating, like dairy and cheese and pasta, and some foods help you go more frequently, like fruits and vegetables, bran, chocolate, alcohol, and caffeine. Some foods are gas producers and make people pass more gas, like onions and cabbage and beans and cauliflower. And people who are more active and have more muscle have more regular bowel movements than people who don't move a lot. Certain diseases and conditions can alter our bowel habits, especially older age-related disorders. Some medications can alter our bowel movements, especially opioid pain medications. Opioids slow peristalsis, which can cause significant constipation. Antibiotics, magnesium, and metformin can cause diarrhea. Surgery and anesthesia slow down peristalsis, which can lead to constipation, and there are many more like this. Assessing a patient's stool can provide us with invaluable information about the patient's GI system and bowel health. Remember to wear gloves when assessing stool, please. When we assess stool, we want to look at how much stool they had. Was it a little bit or was it a lot? If it's liquid, we measure in it mLs, and if it's solid, we just say like they had a bowel movement times 1, or however many they had during the day. We need to assess the odor of the stool. Sounds very odd, but people who have blood in their stool have a very distinct stool odor. Stool infection called C. diff also has its own distinct odor. These odors are so distinct that you can diagnose a person just by walking down the hallway. And we want to assess the consistency and the shape of the stool. Remember, stool should be formed. If it's hard balls or liquid, there's an issue. Look at the stool chart on the right. This shows the different types of stool a person can have. Lastly, we may see things in the stool that don't look like they belong there, and we call these constituents. These can be pieces of food that should have been digested that wasn't. It could be food that's hard to digest, like corn, or it could be non-food objects that get swallowed, like little kids swallowing Legos and coins. We need to look at what color the stool is. Stool should be brown. The stool is naturally brown from the body digesting bile and hemoglobin. If the stool is green, yellow, white, red, black, or a rainbow of colors, we have a problem, and each color can tell us what's going on. Green stool could mean the stool is moving so fast that the bile isn't getting digested. It could be food coloring, or it could be infection. My kids love eating Oops All Crunch Berry cereal because it gives them green and blue poop, and they love it. Yellow stool usually means that there's excess fat or the body isn't digesting the fat. C. diff, which we'll talk about with diarrhea, can also cause yellow stool. Black stool can mean that there is digested blood in the stool from somewhere in the GI tract that's more than just the normal hemoglobin that we digest. This is blood. Some vitamins and minerals that contain iron will also turn the stool black. So this could be a really important question to ask somebody with black stool. Hey, do you take iron supplements? Light colored, tan, or white stool usually means there's no bile getting to the bowels, which means digestion can't take place like normal and there's a problem. Red, bloody, or blood-tinged stool means there's blood somewhere in the stool. Usually blood in the stool means bleeding is in the lower GI tract, like the sigmoid colon or rectum, where black stool is going to be somewhere higher up in the GI tract, like in your stomach or small intestines. Red stool can also mean hemorrhoids or fissures are forming in the rectum from the person pushing too hard, or it could even be from cancer. And this is the end of anatomy and physiology and assessing GI.